Good morning, everybody. Professor Rima, Ubaid, respected sir. So we are going to start our IC168. As is our clinical observation, so is our pathology. Comprehensive ophthalmology includes the clinical and pathological understanding of disease in a systemic way. The clinical pathological aspect help us to know in detail, which include imaging advancements, real-time integration of investigating tools which abreast with the pathology. We'll be discussing the corneal pathology, followed by vitreoretinal lymphoma by Professor Rima. Then we'll be dealing with ocular tuberculosis with, and IgG4 related disease and retinoblastoma. Now, you see clinical pathological aspect of corneal dystrophy, which will be dealt by Dr. Somashila Murthy, who is an exponent in corneal and uveal disease, including her expertise in scleritis. Professor Jyotirmoy Biswas, my mentor, who is the world authority on uveitis and ophthalmic pathology, and he will be delivering on the ocular tuberculosis clinical pathological cases. Professor Rima Bansal from PGI Chandigarh, she had done lot of her works on uveitis and also in vitreoretinal lymphoma. She will be delivering the case-based presentation. And I'll be discussing the case-based retinoblastoma cases and clinical pathological cases of IgG4 related disease will be delivered by Dr. Ubaidur Rahman, who is at present at Shroff Eye Institute, and he did his fellowship from Shri Shankardev Netralaya Oculoplastic Department. So I invite Dr. Somashila Murthy to deliver her lecture on clinical pathological aspects of corneal dystrophy. Dr. Somashila.
Very good morning, and thank you very much. Firstly, I would like to thank Dipankar for including me in this course. Pathology has always been one of my very subject that I'm very interested in. Dr. Murthy, the folder is called, the presentation is called Dr. Murthy. And so I also am, of course, very interested in cornea. So putting the two together, I thought I'll discuss 3 cases which are basically corneal dystrophies, but maybe a little bit unusual in their clinical presentation, or maybe usual in the clinical presentation, but this is how pathology really helps us in classifying and differentiating amongst the various corneal dystrophies that we have. So straight away I'm going to jump into the case. The first case which we saw during the COVID times is 37-year-old, and he had undergone LASIK in both the eyes in 2004. He was doing well, he said, for almost 12 years after LASIK. And in 2016, he started developing episodes of recurrent redness and discomfort and so on. And then the vision also started becoming blurry for the past 1 year before he presented to us. So nothing systemic, and he said that he had one sibling but who has no eye complaints. When we examined him first, his visual acuity was improving to 20/30 with some refractive error in both the eyes. And this is a clinical picture in both the eyes. What you can see is this very sort of unusual reticular looking pattern of some kind of deposits which were lying in just around the LASIK flap. I'll show you in the OCT where they were located. The anterior segment OCT very beautifully shows us almost like a in vitro pathology what the patient has. So this is the epithelium, that followed by this hyporeflective areas is a thickened epithelium, and then the LASIK flap follows. And both the anterior surface of the flap as well as within the flap as well as its posterior surface seems to be layered by a hyperreflective material, and that is what the material that we are seeing in the clinical photographs are. So the patient was counseled, and initially he didn't want any surgical therapy. Then subsequently, as the vision dropped, we performed epithelial removal with the help of alcohol, and also PTK, which is phototherapeutic keratectomy, to smoothen the cornea and improve his vision. So I didn't want to sacrifice any of the tissue because it is very important for me to know what dystrophy this patient has, because morphologically it doesn't really resemble either granular or macular or lattice. It could be anything. So when we went in ahead for surgery for this patient, in fact, what happened was almost the entire LASIK flap just peeled off very easily when we applied alcohol. So we removed the entire LASIK flap, and this is the histopathological section just of the anteriormost part of the epithelium and stroma. Epithelium is denuded, it's not present in this specimen, most of it, except for here. And this is under low power. When you enlarge it, you can see already that there are some deposits. This is H&E stain, so there are some bluish looking deposits in the subepithelial region, and this is just the flap that is folded upon itself. In high magnification, there are these, this is the hypertrophic epithelium, which is compensating for what the patient has. In some areas it's attenuated, and the epithelial cells, the basal cells, look quite large and a little abnormal. And the subepithelial region, which should ideally be the Bowman's area, is replaced by the presence of these pinkish looking deposits. This is under Mason's trichrome stain. So you have this almost, ideally it should be brick red, but here it's pink, more of pinkish looking deposits. And this is under higher magnification, 40x, you can see the same deposits. So under H&E stain, this is the epithelium again, and then part of the anterior stroma. And when you do Mason's trichrome, this is various, this ballooning is artifactual because we use alcohol and we remove the epithelium. It wasn't truly there in the patient. And you can see these deposits with some even basophilic areas in this. So these orange red deposits with Mason's trichrome is very classical for granular corneal dystrophy. Of course, if you have an entire corneal specimen, this is of another patient, so this is the entire corneal specimen going all the way from epithelium, and then the anterior stroma, this just below the epithelium is the Bowman's. So in my patient, what we had was just this much, just up to the epithelium, and this is the entire stroma where you have all of these very amorphous looking deposits. And when you do Mason's trichrome, this is the almost brick red color that you see for these deposits. So we had clinical diagnosis. We suspected, clinical we didn't have a diagnosis. We were suspecting dystrophy. Pathology helped us, telling us very strongly that it is nothing but granular dystrophy. Now we needed genetics, the genetical classification of the patient, so that we could finally confirm the diagnosis of a corneal dystrophy. However, this patient declined to undergo genetic testing, so that part is remaining. But I think that with 1 and 2, it's pretty obvious what diagnosis the patient has. This is post-therapy in both the patients, in both the eyes, showing very clear corneas. And so far he's not, so this was in 2022. So far he has not had a recurrence of the dystrophy. Very recently, when I corresponded, he said that his sister, who's not undergone any LASIK, but now she's almost in her 40s, is also presenting with blurring of vision, so we've asked them to come for follow-up. So these are both the eyes. So that was the first case. The second case is more classical what you have. So the second patient came to us without any previous surgery, but had decreased vision in both the eyes. What we can see are these very discrete whitish deposits which are in the anterior and mid stroma in this patient with clear intervening areas. So this is almost clinically, the phenotype is classical for granular corneal dystrophy. We don't really need to worry about whether it could be a different kind of a dystrophy. So this is the AIOC2024, which shows that most of the deposits are located just below in the anterior stromal areas. There are some deeper deposits, but they become less dense. So this patient also, we took the epithelium, they debrided it with the help of alcohol, and applied phototherapeutic keratectomy to the anterior stroma to improve the vision, and subject to histopathology. So just for the sake of the two audience who are here, and Dr. JB obviously knows, that in the pathology department, so it is good to take that specimen. What we do is, because the department is right in-house, so we just put it in a small Eppendorf tube, and that tube has formalin in it. So 10% formalin, empty the tube. Typically it has PBS, so empty that and put this formalin and put the specimen. The other way is to use a filter paper and just orient it on the filter paper, so and then label it, which our pathologists really like, but our fellows don't do that. And then it's processed and then sectioned as usual. So this is the second patient where you see under low power, so all the epithelium has curled up. That is why I was saying to spread it out on filter paper. For the first patient we had done that. And these are the classical deposits which are staining with Mason's trichrome, as I showed in the previous case. This patient, we could perform genetic analysis which showed positivity for the TG-beta1 gene. The last case I'll end up with is another patient who's 45-year-old, and he had recurrent episodes of redness and so on, so recurrent corneal erosions basically. And he didn't go all this time in his life for any checkup, because he didn't know that he has poor vision. He thought this is normal vision for what you should have. He seemed to be managing with his left eye, which was 20/40, and in the right eye he had actually very poor vision. So this is how lattice dystrophy could look like. When you look at it with direct illumination, you can just see centrally the cornea looks very cloudy. Of course, there are peripheral deposits also, not shown in this picture. But when you use retro illumination, then you can see all the lattice-like lines in this pattern that are just lit up in retro, which match the clinical pictures that I showed you here. So this patient we subjected to transplant for the right eye, where his vision was very poor, because this dystrophy involved very deep in the cornea, and we wanted to do DALC, but it got converted to penetrating keratoplasty. This is a button. So in the DALC button, what happens is we insufflate air. So all you see is the air in the stroma. So you know how in DALC, if I'm sure Rima wouldn't have wanted to see or bothered to see, but what we do is we inject air, then we dissect out the stroma, then we have to go deeper and so on. So that's why you have sort of in layers. So we dissect out in layers. So you have one layer here with the epithelium and subepithelial region and anterior stroma. So in this layer, we can see the deposits below the epithelium. By now, all of you have become experts at what to look out for. And the lattice dystrophy is amyloid, so we have to use a Congo red stain for amyloid. It stains a little pinkish or red, and this amyloid substance is very well seen. It has apple green birefringence, because it polarizes, and this is what we're trying to show here in this slide. So it's a beautiful sight to see under the microscope when you see this stars in the sky kind of appearance for this dystrophy. So, so again, for this particular patient also, we could have genetic analysis and which matched lattice dystrophy, and it also matched perfectly for the under the new IC3D classification. So that's all I had, and some of the slides are from the new center at Shantilal Sanghvi Eye Institute, where we have cases, and I acknowledge my fellow Dr. Prajakta, who helped me put together this material. Thank you very much.
Thank you, Shamshila. I'm quite impressed with the ASOCT pictures. It's almost looking like histopathology.
Right.
And another point is that, you know that when I was getting training at Doheny Eye Institute, Dr. Narsingh Rao, though some cases like lattice dystrophy was very classic,
Yeah.
he used to ask for a panel of histochemical stain,
Right.
like you do that trichrome, Congo red, and Alcian blue.
Right.
Though they're obvious, it's you know, you can focus it, but sometimes you can have combined lesion,
Yes,
combined dystrophy,
Yeah.
like, you know, granular plus amyloidosis or
Yes.
this. So it will be good practice to do that one, but most of the times clinicians is correct in making a diagnosis.
Yes.
Nowadays, another important thing is that nowadays for pathologists it's little frustrating to get only small tissues like debridement of the epithelium with a little stroma. It becomes a challenge to the pathologist. But it's a very nice, well documented, simple cases. I wish the PGs would have been there, because the corneal dystrophy is a condition which is often asked in the exams.
That's right.
And it's a beautiful.
Just to do justice to our pathology department, our pathologists, they always do all the stains. I just picked up the ones. So in these cases,
all
nothing.
the
Yeah, none of the other stains had any deposits. So
Yeah.
they don't believe us. They do it on their own. So
Yeah. So when I was doing the pathology more intensely, there was no ASOCT.
Right.
Now with the ASOCT, the pathologists have got can narrow down his diagnosis. Histopathology. It might be very helpful.
right. Thank you.
So I think you should do ASOCT in all corneal
Right.
dystrophy.
Yeah. Thank you.
Thank you. Very nice presentation.
Thank you.
So next presentation is a conjunctival lesion. And this is me, and we know me, so that I don't want to introduce myself. So let's show an interesting case. Don't go. There's only two precious audience is there. So this is a clinical pathology of ocular tuberculosis. I should not have given the title, and it's a very interesting case. This is a 26-year-old female. History of swelling in the left eye on the conjunctiva, 1.5 months. Marked dimness of vision in the left eye for 7 days. Very acute. Referred by local ophthalmologist, he thought that it is a squamous cell carcinoma of the conjunctiva. And this is the vision, 20/20 in the right eye. Left eye has got light perception and projection. Slit lamp examinations, right eye normal, left eye multiple KPs were there, and large mass lesion over the superior limbus and multiple small lesions on the temporal side, fundus normal. And they look at the picture, and you won't see this type of pictures very often. A kind of a mass lesion, superior globular lesion. What could be the diagnosis? This title already been given, but it was a challenge to the diagnosis that point of time. And there is a inferiorly, and particularly in the temporal part, there was a kind of a lesions were there that very closely mimics squamous cell carcinoma or conjunctival dysplasia. So this was a diagnosis was made even by us as a squamous cell carcinoma of the conjunctiva. So we didn't have the UVM and all, or ultra ASOCT. So patient's history was quite remarkable, interesting. History of blood transfusion 1996. He developed pulmonary TB 2002, treated with anti-TB drugs, 4 drugs. She get pregnant in January 2003, developed herpes zoster skin lesion, maybe an opportunistic infection due to the HIV. He was diagnosed to have HIV infection July 2003, was put on Girovidin 300 mg twice daily, August 2033, developed swelling in the conjunctiva September 2003. So all the episodes of HIV infection, after that he developed conjunctival mass lesion. ELISA for HIV was positive, CD4 count was not bad, CD8 count is 562 cells per cubic millimeter, total WC count 5,700, and platelet count is normal. ESR was remarkably raised, 125 millimeter first hour. And if you look at the chest X-ray, that time CT scan was not that vogue. This is our, so this is superior mediastinal widening was there. There's no parenchymal lesion. And then this is July 2003, repeat chest X-ray shows superior mediastinal staining. We did the CT scan of the orbit. So particularly to see the extension of the mass lesion, and no evidence of intraocular extension was seen. This is a CT scan picture. CT scan pictures showing that lesion, and there is no extension in the inside. So it's a superficial. Enlarged preauricular and submandibular lymph node was seen, and this could be due to squamous cell carcinoma that can produce preauricular and submandibular lymph node. Now, what is your diagnosis? Diagnosis is obviously known. At the beginning, I told you, we did a conjunctival mass excision and a local anesthesia, and the sclera found to be deficient below the mass lesion. And the scleral patch graft was done. Leukoplekic lesion, which was inferiorly and the temporally, was also excised. And this is the histopathology picture. You can see a bit of epithelium, which is, I don't have pointer here. This is a bit of epithelium was there, which is a little disorganized, and in the stroma, you can see a granuloma, big granuloma. There is a giant cell and lot of lymphocytes and few epithelioid cells. So this from a granuloma, there is no caseation seen in this slide, but if you next slide, if you see the multiple giant cells, And what is very interesting is pathognomic was there under this slide. You can see there are a lot of caseation necrosis and then gel cell formation. This is so classic for tuberculosis. We went ahead and did a special stain that also, no surprise, that also picked up acid fast bacilli on Jill Nelson stain. So this is the patch graft, and specimen one, we go ahead and as we did have PCR facility, we did the paraffin section PCR. MTB DNA was positive and nested primer which detects MPB64 gene. And you can see the blue arrow showing the MPB64 gene. And then surprisingly, that's the small squamous cell kind of lesions, the epithelial lesions temporarily was also positive for MPB64. So it was histopathologic, molecular biologic study, special stain, all indicated that there is a conjunctival tuberculosis or conjunctival tuberculoma, to be very specific. And the patient did well. I followed up the patient, called him and brought him over there, and it was surprisingly, these things once excised and the mass is removed, patient was symptomatically better, and that conjunctival patch graft was nicely taken. So ocular lesion, coming back to the discussion part of it, ocular lesion due to the TB in HIV positive patients, I've seen many of them mainly involve the posterior segment. They have got tuberculoma of the eye or subretinal abscess. And here is a case where we found that there is a conjunctival tuberculoma. I didn't put as a single case. I have made 100 case of an AIDS past 100 cases that I included. So, but otherwise it made it as a separate publication also. And that was a HIV in 100 consecutive cases. There the photograph of this case with the micro photograph is available in, this was in American Journal of Ophthalmology 2000. So thank you very much. I'm inspired by Dr. Badrinath, my Padma Bhushan Dr. Badrinath, who was my mentor and chief, and all my presentation is dedicated to him, to his memory and legacy. Thank you very much.
Thank you, sir. Your presence is more than enough for all of us. And thing is that we'll have a questions later on. And now I invite Dr. Rima for vitreoretinal lymphoma.
So, very good morning, respected sir, and thank you, Dipankar, for having me in your instruction course. So, my topic is on CPC of primary vitreoretinal lymphoma. So, I'll straight away go to, I'll be sharing 3 cases. So, this was a 75-year-old male who came with decreased vision in both the eyes for 6 months, and probably he was just told that he has cataract, and that is the reason for his decreased vision. He had 624 in the right eye, 636 in the left eye. So on examination, by and large, the anterior segment was normal, but when we carefully saw, there were very fine KPs, which could be easily missed on clinical examination. So I've highlighted them with the blue arrows. Occasional cells, there was no, the flare was 0, I mean almost 0. We checked on the LFM. So when we had the dilated fundus examination, we could see a lot of media haze because of the vitreous membranes. We couldn't really comment on what the fundus findings were like. We closely again had a look on the slit lamp, and this is the density of the vitreous membranes we found in both the eyes. This is in the left eye. So we tried to do an OCT in the right eye. We couldn't. So the media was so hazy. Also in the left eye, we couldn't get any scan. So we didn't know what we were dealing with. As per the Sun classification, was it a pan uveitis or a posterior uveitis or simply just intermediate uveitis? We tried to do fluorescein angiography. We didn't find anything except some staining of the vessels here and there. So we got the routine investigations. We were not sure what we were dealing with. He was a 71-year-old male, And the investigations, the baseline investigations that we do in most of the patients were negative, like Montux, TPHAs, CD chest, and HIV. We counseled the patient because we didn't have much to offer at this stage. He didn't have any systemic complaints, neurological or cardiology or anything. So we counseled him that we need to do a diagnostic vitrectomy. We didn't even know whether we were dealing with an infectious uveitis or a non-infectious uveitis, or was it a masquerade. And we planned to send the samples for PCR, cytology, and for flow cytometry. Intra-op, we thoroughly examined the fundus up to the periphery. We didn't find any lesions subretinal or sub-RPE. And our cytologist was quick to give the report of the vitreous cytology, which showed a lot of atypical lymphoid cells with high NC ratio. And the immunohistochemistry showed that the cells were strongly positive for CD20. So a diagnosis of non-Hodgkin's lymphoma, B-cell type, was made in this patient. So the PCRs were negative. The IL-10, IL-6 ratio was also high, corroborating with the diagnosis of primary vitreoretinal lymphoma. Now we got a neurology consultation, though he didn't have any neurological complaints, and the MRI brain showed widespread involvement because of CNS lymphoma. So the left eye also had dense vitreous membranes. We took him up for vitrectomy. Now this time it was a diagnostic as well as therapeutic vitrectomy. You can see the media clearing up so well after the vitrectomy, vision getting back to 6/9. You could easily get good OCT scans. Similarly, in the right eye, post-vitrectomy, the vision improved to 6/12, and the OCT scans were nicely obtained. So this, going back to this case, our suspicion of lymphoma came from the dense vitreous membranes, few KPs in the anterior segment, and the age being 71-year-old. Now this was a 61-year-old female who presented with 6/6 vision, but her only complaint was floaters in the left eye. And on clinical examination, the anterior segment was normal. The fundus examination showed these multiple hypolesions scattered all over, more in the left eye than the right eye. And she was symptomatic in the left eye for floaters. And she was very, very particular about the floaters disturbing her. We got the autofluorescence done, and we found this stippled pattern of autofluorescence in both the eyes, more of hypoautofluorescent lesions scattered, and they were more seen on autofluorescence than seen on clinical examination. Now, when we got the OCT, primarily there was no cystoid macular edema, but what was striking were these subtle sub-RPE deposits in both the eyes. So we subjected her, again counseled her for a diagnostic vitrectomy, suspecting it to be a case of primary vitreoretinal lymphoma. The flow cytometry of the vitreous fluid showed a very high IL-10 as compared to IL-6, again pointing towards PVRL. PCRs were negative. We got her neurology consultation, and when we told the neurologist that we are suspecting a PVRL, they did the CSF tab, where also again the IL-10 ratio was high as compared to IL-6. The vitreous cytology showed some cells which were atypical. The cytologists were thinking of a low-grade lymphoma. Majority of the cells were CD20 positive. CSF tab was repeated twice when we consulted the neurologist. There were no malignant cells on cytology. MRI brain was normal. Since the MRI brain was normal, we took her up for a PET CT. There was no uptake. So because there was no evidence of systemic lymphoma so far, our oncologists were not in favor of giving her a systemic chemotherapy. So she was subjected to local intravitreal chemotherapy. So this was a case of primary vitreoretinal lymphoma, low grade on cytology. Now this was a third case, 61-year-old female presenting with poor vision since many years. She was not sure of the history, but her clinical examination showed she was bilateral pseudophakic, didn't improve, had any improvement in vision after cataract surgeries. And when we did the dilated examination, what was striking was in the right eye, we found this white glow. Now, this is not a normal glow. So when we saw the fundus, the media was hazy, and all that we could see was there was a dense opacification of the posterior pole, probably some dense fibrosis, not really sure because of the media being hazy, and a lot of pigmentation around it. So we again carefully saw the anterior segment, and we found that there were subtle KPs in the right eye where we had this white glow. So this is the fundus examination of the left eye. Something like retinitis pigmentosa like retinopathy. We tried to do an OCT, we couldn't get the OCT through the right eye, but left eye this showed this kind of subretinal fluid and disorganization of the inner neurosensory retina. If you can see, we can hardly appreciate the retinal layers on the OCT and something abnormal which is going on. You have a pale disc, you have a lot of pigmentary retinopathy in the left eye. So thinking of her age, and at this point of time, because when we looked at the left eye, we thought of a primary vitreoretinal lymphoma. So we counseled her for a diagnostic vitrectomy in the right eye. In the right eye, we obtained the vitreous samples, and when we cleared the media, this you can see that there was a lot of, we tried to dissect this fibrotic membrane, we couldn't, and this membrane was actually subretinal. So you can see any attempt to, access this membrane led to bleeding. So we stopped the surgery there. We just obtained the vitreous samples and subjected them to cytology and flow cytometry. So this is the first post-op day, and the 7th post-op day, not much change except that there is some improvement in the media clarity. The right eye, sorry, this is just the left eye OCT. Now the flow cytometry of the vitreous fluid that we sent showed a very high IL-10 as compared to IL-6. So the IL-10 IL-6 ratio was more than 1, pointing towards primary vitreoretinal lymphoma. And cytologist gave us a report of a non-Hodgkin's lymphoma, large cell type. So this was a high-grade intraocular lymphoma in the right eye. Now, when we look at this fundus picture, what made us suspect primary vitreoretinal lymphoma in this case, because this is not a typical presentation of PVRL. So we searched for pigmentary retinopathy and PVRL. Now, we remember such a case being shown to us when we were being trained by Professor Amod Gupta, a case of lymphoma, following on follow-up having this RP-like fundus. So this made us suspect, and then after we made a diagnosis, and when we were waiting for the cytology report, we did this search and we found the major review on Hodgkin's lymphoma when we put the keywords of retinopathy, and we found that the ophthalmic manifestations of ophthalmic lymphoma includes paraneoplastic retinopathy, and this was a review. Now, I've just highlighted the salient features. This is what the patient reported in this review looked like. You can see there is a lot of bottom panel EF, lot of pigmentary retinopathy, and these were the secondary chorioretinal atrophic changes that occur after the acute insult or after the acute uveitis because of PVRL. These patients can present with night blindness, and this is what, ultimately you have a diffuse RPE atrophy. Another case, we found Hodgkin's lymphoma associated retinopathy, where a case was reported. Now, what was important was this was a 17-year-old Caucasian woman, a young woman, where a bilateral panuveitis led to the diagnosis of systemic lymphoma. Now, what you can see is that the bilateral panuveitis was, when it was active, it had anterior uveitis, it had vitritis, white chorioretinal lesions, papillitis, and vasculitis. Now, when this healed, there was diagnosis of Hodgkin's lymphoma, chemotherapy was given. So in remission, the fundus had pigmented chorioretinal scars, predominantly among the retinal vessels. And on the right, I have highlighted the keywords which helped us get this information from the literature. Now, this is what the patient reported in this case looked like when it had active uveitis, like you can have white chorioretinal lesions, papillitis, vasculitis, and this is what in the healed stage of uveitis both the fundus looked like. You can see the changes much more prominent on autofluorescence. Now, if you just look at both fundus changes in this case that was reported, it looks quite similar to our case in the left eye. So probably our patient had active uveitis, went into healed stage without any treatment, and developed this lot of scarring and fibrosis in the right eye as well as in the left eye. Now, when you look at this case, again, when we go back to that case of the Hodgkin's lymphoma, we were wondering that probably all the reports that I found were restricted to Hodgkin's lymphoma. So is this pigmentary retinopathy or paraneoplastic retinopathy restricted, or it's a feature of Hodgkin's lymphoma or a non-Hodgkin's? Because the reports are of Hodgkin's lymphoma and our patient was of non-Hodgkin's lymphoma. So you can see that our report was of non-Hodgkin's lymphoma. So Hodgkin's versus non-Hodgkin's, is pigmentary retinopathy a feature of either of these or any one of this? So this was again a good review that I found where granulomatous panuveitis was associated with Hodgkin's lymphoma. And they found that the uveitis associated with systemic, this is I think one of my last slides. So the uveitis associated with systemic lymphoma has been predominantly attributed to non-Hodgkin's lymphoma, as we all know. But here in this review, they reported that the clinical features of uveitis associated with systemic lymphoma do not differ between non-Hodgkin's and Hodgkin's lymphoma. However, the age of presentation may be much younger in Hodgkin's lymphoma. This was again another case where retinal degeneration was reported with Hodgkin's lymphoma. So we need to keep in mind many of these patients can present with just night blindness because of the pigmentary retinopathy that we see and can be confused with retinitis pigmentosa because of the complaints and the fundus picture. So a progressive paraneoplastic retinopathy is seen in these patients. The pathogenesis of the retinal degeneration or the atrophic changes seems to be related to the serum antibody which is reacting to the retinal protein of approximately 65 kilodantlins, and they have just given an explanation, a possible hypothesis that the antibodies in patients with small cell lung cancer react with the retinal antigens, and they are the ones which cause retinal degeneration that we see clinically in these patients. So to summarize, we need to keep the age in mind. Many of these patients are in the extremes, but earlier we were looking at patients who were plus 70, now we are looking at patients who are even in their early 60s. So clinical presentation may be typical, like I showed in the second case, like a leopard spot fundus, or it may be non-specific like an abnormal pigmentation in the fundus. We need to look for subtle signs of uveitis, and of course diagnostic vitrectomy and cytological confirmation gives us the answer for the CPC. Thank you very much.
Thank you, Dr. Rima, for this wonderful presentation showing lot of cases. Any question, Dr. Padma, you want to ask?
How do you go about managing those patients?
We face similar challenges where only IL-10 is high. So if you have the facility of mid-88 PCR, you can go for that. So we also have a patient where only IL-10 is high. The oncologists are not ready to start systemic treatment. Cytologist says I cannot give a confirmatory diagnosis of a lymphoma. So we keep the patient on follow-up. We tell the patient that we can give you a local intravitreal chemotherapy, but then you have to be wary, because once you start these injections, they are repeated every week. Or you can go for a combination therapy with rituximab and methotrexate. Lot of ifs and buts, but no definitive answer. So I would keep this patient on a regular MRI 3-monthly. For any fresh symptoms, repeatedly do an OCT where we can see sub-RP deposits, or maybe again keep the other eye ready for a diagnostic vitrectomy so that we have some sample later on for a cytology confirmation. So if you've done vitrectomy in one, just hold on for the second eye till we have some new lesions, or we think that now it's manifesting in the eye.
Thank you.
Difficult question to answer. So
JB sir will make a comment.
So the primary intraocular lymphoma earlier used to be called reticulum cell sarcoma. Reticulum cell sarcoma. I remember Dr. Badrinath diagnosed a case of primary vitreoretinal lymphoma or primary intraocular lymphoma in 1985. I think he is the first person in this country who identified intraocular lymphoma. We took the patient to the cancer hospital, and there was a pathology department. I remember Dr. Natarajan did the vitrectomy, vitreous biopsy, and that vitreous biopsy was papanicular stain was done, and that showed nuclear, like nipple-like projections from the nuclei, and abnormal nuclei was seen. And that case, that patient did not further follow up, but that was the first lymphoma which was diagnosed. So lymphoma diagnosis clinically is there is a variation of clinical features, and there is also challenge to the cytopathologist, where there is no clear-cut picture is seen, lot of inflammatory cells are seen, and single biopsy can be negative, and then you have to look very carefully. These cells are not very many, so you have to look into the abnormal nucleus of the cells, and admixed with the necrosis. I always suspect lymphoma when I see a lot of necrosis of the cells. There is no reason there should be necrosis. Two possibilities. One is that whether it is a tuberculosis where do the caseation necrosis, and second possibility, which is more obvious, is that lymphoma. So it should be clinically suspected. And in anterior uveitis, if we see that lymphoma, primary vitreoretinal lymphoma, the cells are very coarse cells, large, big cells, not that vitreous cells which you see in intermediate uveitis. That's one of the very characteristic sign. And leopard skin is easy to identify. I have seen even apex center lymphoma cases thought to be tuberculosis and given 9 months in anti-tubercular treatment. So early diagnosis is important because there is a treatment available, intravitreal methotrexate, intravitreal rituximab, which can prolong the life of the patient. But I am not aware in my life of 10 years or 12 years, 5 years is now possible. Over 10 years, they don't survive. They develop neurological lesion, and in spite of the treatment, many of them succumb. So there is something to win in these situations. You need to have challenge not only in the diagnosis. Very important thing is the management, and I don't know when you will get the right path.
Thank you, sir, for your such a insightful thoughts. Dr. Rima, I wanted to ask you, suppose the KPs in lymphoma, see, is it some sort of dendritic ages are seen in those KPs, which can confuse with the infectious KPs sometimes?
I haven't really characterized because they're very subtle, and they're likely to be missed. So most of them we have seen when we come back to the anterior segment again, and we see that yes, there is signs of inflammation, something abnormal in the fundus. Then we see, oh, there are tiny KPs which probably are likely to be missed. So I don't think I've never seen mutton fat or I've never seen.
Padma, any stellate KPs in lymphoma?
We get varied morphology, and we have seen pigmented fine KPs like Dr. Rima said, and few stellate-like projections, and also white KPs. They are smaller in size compared to the other ones. So these are the three patterns we have seen. When we try to characterize them on confocal microscopy, we saw the floral pattern. They had both incomplete as well as a complete dentitic kind of a floral pattern, and they disappeared following treatment. So that again we use this as an indirect biomarker, but never have anterior segment inflammation. It correlates well with the clinical activity of the disease.
Thank you, Dr. Padma. I want to ask another point regarding the Hodgkin lymphoma. If you see, in Hodgkin lymphoma, we get certain cells, for example, Reed-Sternberg cell, lacunar cells. Now, is there any histopathological evidence of those cells in all this pathology that you have found in the literature, Dr. Rima?
Histopathological in the eye?
In the eye, of Reed-Sternberg cells and other
I
things?
don't recall. I don't think so.
Okay.
They were systemic cases of Hodgkin's lymphoma.
Okay.
So I don't recall any patient being, from the eye being reported.
Because Hodgkin lymphoma is very, very rare for the eyes, for orbital lead lymphoma. That's one point. And secondly, one point I wanted to tell that IL-10 is increased in lymphoma, whereas the IL-6 for the inflammatory causes.
Yeah.
That is and there's things. So thank you, Dr. Rima. Thank you so much for.
Thank you, Dipankar.
Now I'd like to invite Dr. Ubaid Ur Rahman. He is from Shroff Eye Institute. He will be speaking on IgG4 related disease, and he had a few publications on this IgG4 related disease. Dr. Ubaid.
So good morning, everyone. I'm going to start by thanking Dipankar Das sir, who's been a great mentor to me, and I'm very grateful to be in this instruction course amongst the great minds in ophthalmology. So my topic for today is clinicopathology of IgG4 related disease, and to look at what is the IgG4 antibody. So IgG is the most common antibody in the body, and it has 4 subclasses, 1, 2, 3 and 4. And out of all those 4 subclasses, IgG4 is actually the least common subtype of IgG antibody, and it has been linked with chronic exposure to antigens, and it has also been observed in allergic conditions, helminthic infections in conjunction with IgE antibody. So IgG4 related disorders are a diverse group of inflammatory disorders that are characterized by influx of IgG4 positive cells in the affected tissues, high serum level of IgG4, and they can affect multiple organs. And IgG4 related ophthalmic disorder is when this IgG related disorder affects the orbital or the ocular tissues. So we'll be looking at 2 cases. This is case number 1. This was a 66-year-old male who presented to the oculoplasty clinic with painless and progressive swelling in his eyelids for the past 6 months. On further systemic examination, we saw there were enlarged submandibular glands, which can be seen here in the photo, and these masses had a very firm rubbery consistency. On evaluation, even his parotid glands were enlarged, and the consistency of all the 3 types of swellings were similar. So we advised imaging to this patient, and the patient returned with a CT scan of the orbits. On the CT scan, you can see there's a homogeneous hypodense lesions in both the orbits in the lacrimal gland region supratemporally. And if we look at the axial scan, you'll see there's a spillover of these lesions into the eyelids. So there is eyelid swelling also, preseptal swelling, and going up to the nasal side from the temporal side. So in our mind, we kept diagnosis of lacrimal gland lymphoma, Mikulicz syndrome, and Sjogren syndrome. And lacrimal gland lymphoma can be bilateral also. However, this patient did not have any reduced Schirmer's and no dry eye symptoms. So an incision biopsy was performed from the left lacrimal gland, and histopathology was studied. On seeing the histopathological slides, there was a very rich lymphoplasmacytic infiltrate, and germinal center formation was also noted. So following histopathology, immunohistochemistry strains were done. This patient was positive for CD20 and CD3, so both pan B cell and pan T cell markers. Then he was positive for CD138, that is for plasma cells, and his positivity for IgG4 positive cells was more than 50 per high power field, and there was polyclonality in the form of lambda and kappa positivity. So blood testing was also performed for this patient by a rheumatologist, in which serum IgG4 levels were highly raised, but other autoimmune profile was totally normal for this patient. So a diagnosis of IgG4 related orbital disease was formed, and the patient was started on a tapering dose of oral steroids along with mycophenolate mofetil. Unfortunately, I don't have the follow-up pictures of this patient, since this patient was from outstation. But a close follow-up was maintained over video consultation, and reduction in all the swellings was noted. Case number 2 is a young female who presented to the uveitis clinic actually with diminution of vision, pain and redness for past 6 months. Her visual acuity in the right eye was counting finger close to face, and there was a lot of congestion and redness as can be seen. On evaluation of the anterior segment, there were 360 degrees posterior Seineke formation and hypopyon. And on close observation, there was an iris bulge in the inferior region, confusing us with a retroiris mass. So an ultrasound B scan was done for this patient. A mass lesion in the ciliary body region was noted, following which the patient was advised for MRI orbits. And even in the MRI orbits, it was confirmed that there is a ciliary body mass. So we kept two diagnoses in mind, the first one being a ciliary body melanoma and a second one of medulloepithelioma. The patient was counseled for right eye enucleation, and following enucleation, on grossing of the specimen, a white tan grayish mass was seen in the ciliary body region, which can be seen. There's no pointer, but in the ciliary body region there's a whitish grayish mass, and just behind that is a retinal detachment. So on histopathology, again a very rich lymphoplasmacytic infiltrate was noted in this patient, and the immunohistochemistry was similar to the first patient, and IgG4 positive cells were again exceeding more than 50 per high power field. On her autoimmune profile and blood workup, serum IgG4 levels were highly raised. This was the only abnormal blood workup noted. All the other blood workup was normal. So IgG4 related disease is a relatively newer disease which was described in 2001 in Japan, and it's a fibroinflammatory disease with formation of mass lesions with IgG4 positive plasma cell infiltration. Although a median age of 58 to 67 years has been noted, but it can also affect a younger age group. And IgG4 related disease is more common in males, but when we look at IgG4 related ophthalmic disease, it has a similar predilection for males and females, and it can involve multiple organs and lead to autoimmune pancreatitis. There is ophthalmic involvement, there can be sclerosing cholangitis, lymph node masses, autoimmune nephritis, and even retroperitoneal fibrosis. The most common systemic organ affected is the pancreas, followed by the orbital lesions, and most common ophthalmic the part affected is the lacrimal gland. So lacrimal gland is overall the second most common organ affected, and if we look at the different sites where it can affect from the lacrimal sac to the lacrimal gland, cases have been described in the sclera, in the uvea, in the optic nerve sheath, orbital apex, in the fat tissue of the eye, and even in the extraocular muscles. But 69% of IgG4 related ophthalmic disease will involve the lacrimal gland, and out of those 48% will be bilaterally affected. So the pathogenesis of this disease is very poorly understood. Majority of patients have associated allergic conditions, and there may be a correlation with that. There may be a modified Th2 response. So there have been various hypotheses that have been put up. One of them is role of molecular mimicry with infection of H. pylori and E. coli, which might lead to autoantibody formation in this disease. So clinically, the patient usually present to us with an insidious onset of mass lesions with a relapsing and recurring course. And in the eye, mostly lacrimal gland, as I mentioned before, is affected, followed by the various soft tissues in and around the eye, the extraocular muscles, optic nerve, and even there can be nerve infiltration of the trigeminal nerve, of the infraorbital and the supraorbital nerves. So usually, since lacrimal gland is the most commonly affected organ, patients will commonly present with a painless proptosis, associated eyelid swelling, and if there is a posterior lesion, then maybe reduced vision. Then atypical cases that have been described in literature have included uveitis, uveal mass, which was seen in our second patient, scleritis, and even conjunctivitis. And out of these patients who have ophthalmic disease, 75 to 100 patients will also have extraocular manifestations. So a systemic examination is very crucial in these patients. So in imaging, CT or MRI will show bilateral symmetrical diffuse enlargement of the lacrimal glands, and depending on the site, there can be soft tissue thickening in various organs. Then MRI can also show enlarged supraorbital and infraorbital nerves, and sometimes these nerves may even become thicker than the optic nerve on imaging. Then PET CT scan is another important scan that can be done in this patient, because it can pick up involvement of all the other organs by showing high uptake of FDG. and which might not be picked up by conventional clinical examination. So PET CT can actually guide us in maintaining therapy of the patient and if any intervention is required. On histopathology, as was seen in our two patients, there will be a dense lymphoplasmacytic infiltrate, there can be germinal center formation, and obliterative phlebitis, although common in systemic IgG4, is pretty uncommon in ophthalmic IgG4, and IgG4 positive plasma cells will be seen. So these are the diagnostic criteria that have been given by the Japanese study group for diagnosis of IgG4 related ophthalmic disease. Number one, showing enlarged lacrimal glands or the affected organ, which was seen in both our patients, although the gold standard always is histopathology. And IgG4 positive plasma cells are usually more than 50 per high power field for ophthalmic disorder, but for the systemic disorder, this count is more than 10 per high power field. IgG4 to IgG4 plus ratio more than 40%, and raised serum IgG4 levels, although in 30 to 40% patients these may be normal. There is another study by the American College of Rheumatology that came out in 2009, and they gave a three-step criteria for diagnosing IgG4. In the first step, there should be involvement of at least 1 out of 11 described organs. Then the second step is very cumbersome. So you have to look at 32 exclusion criteria that involves clinical, serological, pathological criteria. And then after exclusion of these 32 criteria, there's a third step in which you have to look at 8 different domains. Again, they have imaging, clinical, microbiological, pathological, a lot of criteria. So it's a very cumbersome classification and not usually followed, but a total score of 20 in this classification can carry a specificity of more than 99% in diagnosing IgG4. So important differential diagnosis that should be kept in mind whenever dealing with IgG4 disease. The first one is idiopathic inflammatory disease, but it's going to differ from IgG4 in having symptoms of sudden onset of pain, inflammation, and extraocular movement restriction, which is usually not seen in IgG4 disease. Another very important differential diagnosis is a marginal zone B-cell lymphoma, which can share certain common findings with IgG4 related ophthalmic disease, such as lymphoid cells. Even raised IgG4 levels in the serum and in the tissue can be seen. Then thyroid orbitopathy, although it will have very different set of symptoms and clinical signs, it should be kept in mind. And vasculitis is another common differential diagnosis of IgG4 related ophthalmic disorder. Again, there will be periocular pain in any vasculitis, and sarcoidosis can be another differential diagnosis. So there are no standard treatment protocols for management of IgG4 disease till now. Systemic oral steroids are usually the first line of treatment and can be started at 0.5 to 1 mg per kg. And since IgG4 has a relapsing and recurring course, the tapering should be slow and a low dose should be continued for a longer duration of time. Immunosuppressives form the second line of treatment. They are the steroid sparing agents and can also be used in steroid refractory cases. Then there's targeted therapy of rituximab, which is anti-CD20, so it can halt the conversion into plasma cells. Radiotherapy can be used as an adjunct to medical therapy, usually is not employed, and surgery is not preferred in this disease because of a lot of scarring. So IgG4 is a great mimicker. It can mimic inflammation, it can mimic tumor, it can mimic infection. So there should be a high clinical suspicion whenever dealing with these patients. Thank you.
Thank you, Dr. Ubaid. Any questions for him? Padma?
They're refractory to treatment because of the scarring and the fibrosis. In that situations, we found that especially the orbital lesions respond to the local steroid injection. What is your opinion on that?
I don't have much experience with a local steroid infection. Usually the cases I have seen have responded well to systemic steroids. But in orbital lesion, a low dose stereotactic radiotherapy might also be helpful in conjunction with the medical therapy.
Only thing is that the IgG4 related disease is a systemic disease.
Yeah.
The pancreas can be involved, liver can be involved. So you see, serum IgG4 is increased in those situations. So particularly local therapy will not that effective, because if there is any other focus, that have to taken care by the systemic treatment out of it.
Yeah, we had a patient with systemic involvement was not there, only the orbital form was there. So in
Okay.
that particular condition, in addition to the systemic immunosuppressive therapy and low dose of systemic steroids, she responded to 2 or 3 periocular steroid injections.
Okay, then you have to follow up the patient.
Patient.
That's the main thing. Thank you, Padma. Thank you, Dr. Ubaid.
Thank you.
Yeah, JB sir, please give your comment.
See, it was in 2005, I was in Hong Kong. There is a doctor whose name is Dr. Hunter Nguyen. He published a series of cases of orbital IgG4 mediated disease, and he was one of the first to describe this. He showed me how is the IgG4 disease can present. The scleritis is another condition where you should see IgG4, you should suspect. And nowadays there is that lymphoplasmacytic infiltration where you do not find any etiology, no pattern. IgG4 mediated disease we should suspect, and the serum IgG4 should be done in such cases. So it's you have to keep a very inquisitive mind to find out the IgG4 mediated disease. They are much more than what we expect.
Thank you, sir, for this wonderful insight on IgG4 related disease. Thank you, Dr. Ubaid. Now, next 12 minutes, I'll be giving insight on clinical pathological cases of retinoblastoma. I've selected a diffuse retinoblastoma. I do not have any financial interest in any of the material discussed here, and this is purely an academic one. The case 1 was 5-year-old female from South Assam and presented with blurring of vision in the left eye with floaters. She was referred from Silchar Medical College with a diagnosis of intermediate uveitis. Now, she was adopted child, second baby, no complaint in infancy, and vision was 20/20 in the right eye and 20/30 in the left eye. IOP was raised in the left eye. Now, when we saw the slit lamp, there was certain deposits in the eye, in the anterior chamber, and the seedings were not seen, and you can well appreciate their pupil was constricted. Immediately we have dilated the pupil, and you see there was a endophytic retinoblastoma, which is a whitish colored lesion, 9 into 10 mm it was documented. There was a mild hyperemic disc was noted in the right eye, and other eye was within normal limit. B-scan ultrasound was done. So because of the no comment was made on the intraocular mass, sonologists felt the child was uncooperative at this point of time. But when it did the anterior segment OCT, there was a deposit in the anterior chamber along with the seeding on the posterior surface of the corneal endothelium. The provisional diagnosis was made anterior chamber retinoblastoma seed and group E retinoblastoma, endophytic growth with vitreous seeding. Secondary ocular hypertension. In the right eye, there is an optic disc hyperemia. Otherwise, the eye was normal. In MRI scan, it showed 8 into 9 mm lesion abutting the inferior lateral globe wall on the left side with flecks of calcification without optic nerve or extraocular spread. The examination under anesthesia confirmed the clinical finding. Patient was sent to local cancer institute for 3 cycles of chemotherapy. Now, the patient did not improve, the anterior segment seeding did not improve in spite of 3 cycles of systemic chemotherapy. So we decided for enucleation in the left eye under general anesthesia. And this patient, this is the enucleated eyeball with a long optic nerve stump. You can see the deposits and seeding. This is a transillumination depth, and this is a cut section showing the tumor, and this is a Bradloff technique showing the tumor. Now these were measured accordingly, and most important dimension, the basal diameter of the tumor was around 12, height was 8 mm, and maximum thickness was 7.8 mm. Percentage of vitreous cavity involvement was around 40%, and distance from the anterior edge to the tumor was 0.3 mm, and distance from the posterior edge to the optic disc was 7 mm. Now these are the different end phase and the gross specimen documentation of the retinoblastoma case. These are all deposits, and this you can see in the cornea, the isolated seeding can be seen. In raw specimen cornea, you can see the seedings as there, and in the corneal endothelial cells along with the seedings were evident. Now we see the single seed of a retinoblastoma from which the individual cells are percolated inside the cornea, which was documented. And central retinal pigment atrophy was seen in retinal raw specimen with a fluorescent stain. This we had published that there is a atrophy in the central area because central RP has a nucleus there. When the chemotherapy is given, that eat up the nuclear area, and this was also confirmed with the histopathological finding. This is in the virtual stain how the seeding looked. And in histopathology, there was anterior chamber involvement was seen, anterior surface involvement of the cornea, and ciliary processes were also involved. And you see in higher magnification, there was a iris involvement was seen in the anterior side. The tumor is necrotic. As we know, the chemotherapy was given in the patient, and subsequently the portion of the retina was tumor was seen arising, the preretinal seeds and the central RP atrophy in monolayer were also seen. Photoreceptor degeneration were also evident. Lateral calot did not show the tumor, and cut end of the optic nerve, no tumor, but the atrophic changes were noted. So in histopathological diagnosis, what is important, it was an endophytic, corneal stromal involvement, and chemo-induced RP atrophy and other things were seen. Histopathological grading was G4, and AGCC pathological classification was PT2B. Now, prosthesis was given in the patient. Metastatic workup was done by oncologist. Patient is currently on follow-up on medical oncologist at the local cancer hospital. Second case is also very interesting. It's an 8-year-old from southern part of northeast India, the state Tripura, complained of progressive diminution of vision. Family history showed bilateral retinoblastoma in a elderly boy who is 2 years, and there was a 4 years prior from this patient. Visual acuity was normal in the right eye, perception of light in the left eye, and IOP was raised again in the left eye, and no lymph and adenopathy was seen. This is ectropy and UVA and neovascularization and seen. And you see, when we saw for the first time, it was appearing as a xanthophilic lesion with the blood vessel, but there is no telangiectatic vessel, giving a differential diagnosis of a Coats disease. But when B-scan ultrasound was done, there was there was a laterally spreading tumor was there, but there was no calcification detected. This patient also, because of a diffuse retinoblastoma, enucleation of the left eye was suggested. This is the eyeball we showed. Now this is how generally we do a site determination of the tumors. This is how the enucleated eyeball examined in the pathology lab, and different measurements that are being carried out. And this is the proceeding of consciousness meeting from international retinoblastoma staging, how the lateral calots are being made, and this is the way how the central calot and the lateral calots and cut end of the optic nerve are seen. These are the lateral calots which we have to see meticulously in retinoblastoma for this. And coming to the patient here, you can see the diffuse involvement of the retina by the tumor, and the maximum basal diameter was 6 mm, height was 7 mm, thickness was 5.5 mm, percentage of vitreous cavity involved around 45%, and distance of the anterior edge of the tumor was 0.4 mm, and distance from the posterior edge of the tumor to the optic disc was 1 mm. These are the, again you see in the raw specimen, seeding along with the blood vessel which are being evident there. Again the central RP atrophy which was seen in the fluorescent stain in raw specimen. Photomicrograph of the normal cornea was seen here, and angle of the anterior chamber was normal, and this is the iris portion was also normal. You see the tumor retinoblastoma blue cells, basophilic cell arising from the retinoblastoma, which is very important, and the cystic changes which are being seen. This is the higher power of the same photograph. You can well appreciate cystic spaces in between retinoblastoma. These are the exudative area and the cystic changes that has been seen. These are the undifferentiated retinoblastoma proliferation in low power. This is in the high power of undifferentiated retinoblastoma. Lot of necrosis was seen in this tumor, and there was no choroidal involvement in the lateral calots. Photomicrograph of the cut end of the optic nerve was free from the tumor, and this is the cut of the optic nerve which showed a free from tumor. So this is again a diffuse infiltrated retinoblastoma was diagnosed, undifferentiated, and grading was G4, and AGCC8 pathological staging or PT1, and there's a hereditary factor of H1. So retinoblastoma is the most common primary intraocular malignancy in childhood, occurring in 0 to 3 years of age. No sex predilection of in India around 2,000 cases per year is seen, and 25 to 30% cases can be bilateral. We see RB1 mutation in some cases, and in younger patient we see MYCN mutation in 3% of the cases. 60% are sporadic and 40% are familial. So what we understood in this case was that both the cases were atypical, and first one has anterior segment group E retinoblastoma with histopathological high risk factor. Second one was diffuse group E retinoblastoma without a high risk factor. Familial involvement was seen in second case, and anterior segment deposit did not respond to systemic chemotherapy in the first case. Gross and histopathological study in those atypical retinoblastoma was important. Pearl in diffuse RB, it can mimic other disease, particularly uveitis, can sometimes causes misdiagnosis. Pseudohypopyon, iris color change, AC flare, cell hemorrhage are important. Mean age around 5 to 7 years, and usually male are more than female, unilateral more than bilateral. For positive family history can be seen in four cases in out of 77 cases in the publication by Train et al. And symptoms include decreased vision 48%, redness 45%, pain in 35%, leukocoria in 24%, whereas 60% is seen in other RB, discoloration of iris in 14 cases. In signs, vitreous cells in 79%, pseudohypopyon in 48%. More than half of the cases can be wrong diagnosis with subretinal fluid, iris neovascularization, cataract, retinal detachment, uveitis, toxocara, endophthalmitis, and trauma. Absence of mass and calcification, growth spread is slower, and RB gene mutation in Train et al. Study was seen in around 3 out of 4 cases. So thank you for patient hearing. Any question? I think Hanover sir is there. Any question from? Thank you.
So, Dipankar, that is There's a very nice histopathologic demonstration and there is a clinical correlation. One of the point I want to highlight that retinoblastoma remains in the children mostly, but there are reports, and we have reported 2 cases of adult retinoblastoma. So keep your mind open, and if the features are suggestive of retinoblastoma, that like whitish mass lesions, seeds, do for the vitreous biopsy or fine needle aspiration biopsy and just confirm, and then may require enucleation or other forms of treatment. So adult retinoblastoma is an entity, so it's not the retinoblastoma occurs in the children only. And as you have shown, the diffuse infiltrating retinoblastoma is a real challenge. Ultrasound becomes a non-calcification, but if you have got UVM and anterior segment OCT, you can pick up.
Thank you so much, sir. So we are almost in time. If you have any questions for Somashila, I think she's not there. So thank you, JV sir. Thank you, Somashila. Thank you, Rima, Ubaid, everyone. Thank you, everyone. So we conclude the session. Thank you.
I'd like to thank AIOS Scientific Committee for selecting this one. Ophthalmic pathology, as is told, as is our pathology, so is our practice. So as the ophthalmic pathology, so would be our ophthalmic practice. We may understand a lot of pathogenesis of many diseases and characteristic features of these diseases, which may make our clinical work more interesting, more pleasant, and more meaningful.
Thank you, sir. Thank you so much.